presenting you with your certificate in due course, we need to make sure that the certificates make it clear the authentication for CLE. All right. If you need a break, we're in an enclosed room, it's air conditioned, it's lit, but it's not sunlight. You're trapped in your seats with a mad Englishman. You know, this is perhaps something, we don't want you to have a psychotic episode. So please, if you need a break from the room, do please say so. May we have a short break? Fine. I will not be offended as long as we can make it a short break, but we will have our official breaks mid-morning, lunchtime, and mid-afternoon anyway, okay? If we do that, it refreshes the brain, we come back, and we have a more productive time anyway. So I'm quite happy to do that. All right. Anything else that I need to be saying? Yes. Many of the things we will talk about are areas in which you already have expertise. I'm aware of that. However, the challenge for you is to look at them and say, am I using all of these things? Am I using them all as often as I should? Am I using them as effectively as I should? Yes. And also, which of my patients and support groups can I use them with? I readily accept that certain of the episodes in psychotic disorders eliminate some of the things that we can talk about simply because the disorder itself is so severe that communication becomes very, very difficult. It's very difficult to motivate somebody who is at a very low ebb. It's very difficult to motivate somebody who lacks insight. And so, there may be a limitation there on what we can do in those areas. Please bear that in mind. I'm not a magician, any more than you are. So, I'm sure we can work together on that basis. All right. Let me just put up here for you what our aims are for the day. And the second one. I think compliance is a major issue, is it not? Yes. Yes. All right. And the final one. The final phrase there applies very directly to those of you who are working in the private sector. Obviously, retaining your customers is terribly important to you. I would suggest that even if you're working in the institutional sector, that this is still important. You know that you can help your patient if for some reason the patient loses trust and confidence in you and goes somewhere else, or perhaps starts trying alternative remedies, self-help, that kind of thing, then they will not do so well. And I'm quite sure that your professionalism would want you to retain the trust of those people so that you could continue to help them. Although I guess some of you have very crowded patient lists. I think that's certainly the case in the institutional sector. So that's what we're trying to do. Now, we're going to look at key areas. We need to look at communication with the patients and the patient support groups, and we will start by looking at what the difficulties are, discuss some of the things that we can do to deal with that. We need to look at some of the difficulties that come from the way that people are. Now, some of that will be because of their psychosis or neurosis. I understand that. So as we've said, a limit to what we can do in that area. But all of them are human beings. They have personality traits, they have pressures on them. Even the support groups, the family groups, may well be in a very bad state and very disturbed because their relative is shaming them as they see it, or causing them great disruption in their family. So there are some difficult situations there that we have to, or you have to handle as the psychiatrist. So we'll look at some of the things that will help us in that area. The compliance issue is obviously very important. It seems to me that if you are losing the commitment to compliance, then you have more problems, more time is spent, and the patient takes longer to recover, or at least, shall we say, to stabilize. That therefore makes it a pretty important area to look at. And so we will be looking at motivation aspects and how to communicate that, because clearly that's the essence of the day. And how to deal with the resistance when it comes along, because this is the point where, despite all your good work in diagnosis and setting out a treatment plan, if they then say no, don't want to do it, can't afford it, don't want to have the weight gain, don't like the side effects, whatever the resistance is, at that point all your good work can be lost if you can't answer that satisfactorily. So we'll have a close look at how we might deal with those particular issues, and I want in that area for us to actually look at, yes, what's the psychology here, what's the best way to do it, what are the things we should do and not do, but then what we will do is we will put up here the key areas that you're finding difficult, and we'll do a little workshop on them. Okay? So that's the shape of the day. So we start off with communication, because clearly that's the area, and you know, maybe you should be teaching me communication. What worries me, this will be the 4th day in the row that I spent with psychiatrists. When I go home overnight tonight, I will either think I'm a psychiatrist, or I might actually think I'm a psychotic. I'm not sure which it is. My wife will judge when I get home. She'll say, what have they done to you? So, and it's nice to see the smiles. So here, we'll put you into small groups, and here is the area that we'd like you to address, okay? Clearly, the communication is important with the patients, with the support group. Fine. What are the areas that become difficult? What are the barriers? What are the bottlenecks? What are the essential difficulties that you face? Where do they come from? One thing we did in a previous workshop was to separate this into those difficulties which come from the patient themselves and their family. And those difficulties, says he carefully, that come from you, the doctor. Okay? And I see some nods around the room. Thank you for that. That suggests that you're open-minded about that. Yeah, we're human beings. So we are under pressure ourselves. We have our own little foibles, our own prejudices, and our own pressures. So we can make mistakes. All right. So that's the two areas. If one person in the group can make a list, we'll then put them up here, and it gives us something that we can work on as we go through the day, so that it relates to some of the things that you think are important rather than the things that I think are important, but within the framework I've outlined. Okay, are you happy with that? Yes, okay, fantastic. So, how many are you doing? 1, 2, 3, 4, 1, 2, 3. Oh yes, that's perfect. Gentlemen, 4 of you down to the, just before the gentleman in the suit. And then from the doctor in the suit to the gentleman in the dark shirt, please, if you would be another group. And then 4 round to there, and that gives us a group of, I tell you what, we'll make that 5. Would you join that group? Oh, no, of course, you're Janssen, aren't you? So that's fine. So there's 4 there, and then finally we have a 4 here. If you would find it easier to take yourself out of the room for 10, 15 minutes to do this and sit there to do it, then that's fine. I'll leave that up to you. You know, you're not in school. You're adults, aren't you? Besides which, there's more of you than me, and you might beat me up. Yes. So whichever is more comfortable for you. Are there any questions? Are you happy with what you have been asked to do? Yes? Wonderful. Thank you. So I stop talking, you start talking. Okay. So I'll leave it to you. personality clashes. We will look at how we might reduce that. Okay. So, any more from this group?
Extremes of age.
Extremes of age, yes. Age gap, we'll call it. If I can fit that in there.
The population of drug abusers who usually face manipulations, manipulative patients.
Okay. All right. And over to here, please.
The patient-therapist gender differences.
I'm sorry, I'm not getting it.
Patient-therapist gender.
Gender differences, yes. I thought that's what we said. I'm sure I'm going deaf.
Negative transference.
Yes.
Transference.
Okay. And this group here, please. Anything to add? All right. Anything from anybody on this area?
The expression.
Costs. Some patient becomes not cost.
We did. Yes, we did. Yeah.
The expression itself. Many of our patients, they are not able to express their own emotion or feeling, and that is difficult.
Okay.
Mute patient for whatever the cause.
What side?
Mute patient.
Mute patient.
Whatever the cause.
Okay. Well, we've got quite a few things there to look at. Which would you say are the three most difficult for you? Stigma? Language. All right. You might be interested to know that even in the UK, we're supposed to be more advanced. We still have this. We still have the stigma. Okay, I think psychosis is being understood a little bit more, and people are seeing that as an illness. It's on the increase, sadly, because of drug abuse. And it will get worse in the future because so many teenagers are using drugs rather too early in their life on a regular basis. But you know, things like depression, a man doesn't get depression. If he does, forgive me, he's a woman.
It's a weakness.
It's a weakness. It's a weakness. Oh yes, it's okay for women. They get, you know, a little bit sort of down. But you know, there is still that stigma that if a man is off work because of stress or depression, then you know, he's not really a proper man. So it takes a long, long time for that to be removed. Yes, because the difficulty here is that there are also religious aspects to it, and if the behaviour is offensive in that area, then the stigma becomes greater. All right, let's do the other side of it. Okay, someone pointed out that he works in an institution and the institution causes barriers as well. Okay, I'm not going to get into the politics of your employment arrangements, but we can put up here what's relevant. So this time perhaps we can start with this group. Okay, so the doctor's attitude. Any particular example of that?
You know, being rigid, no flexibility with patients, being no empathy.
Yes.
It's like
All right.
a checkpoint.
Yes. Fine. All right. Thank you for that. One from the back, please.
Medical jargon.
Jargon. Okay. Yes, indeed. Fine. Thank you. And from here?
Dissatisfaction. No
Dis-
dissatisfaction.
Ah, yes. Okay. Yes, it does make a big difference, doesn't it, to how how much effort and, what can I say, personal involvement that you put into the job when you're not feeling very happy about it in the first place. It affects your motivation. It's affecting that, then clearly you will make less effort. Do the minimum. Okay. This group, please.
Medical training.
Medical training.
Inadequate.
Oh, inadequate training. Right.
Time limitation.
And time. Yes, absolutely. Any more from you, please?
I think I would mention the problems at home on the physician's side. Like if he has any his own issues and problems reflecting on his work.
Yes, I imagine if you left home in the morning worried about a sick child or having had an argument with your wife or your husband, it does tend to affect your communication somewhat. Or if you've had an accident on the corniche coming in, you know, it's not very helpful, is it? Okay, any more?
The setting, ER, for example.
Okay, yes, I'm with you.
Stress as regards the time or volume of work. And we have some, what we call burnout syndrome.
I'm sorry?
Burnout syndrome.
Burnout.
Burnout.
Ah, yes. Mm. Yes. Yes, it's wonderful to be committed to your job. But I often say to people when we talk about time management, you need to have, even if you get nothing else out of being better at time management, it's getting back some of your own time and the ability to use that to relax properly. Otherwise, you run the danger of becoming a workaholic. And the workaholics that I've met in my career have all ended up like that. Yes, people who used to do my kind of job, and there is some pressure in it, and can't stand in front of a group anymore. Can't do it. Just burnt out totally. So you do need to be very careful. All right, and our friends here, please.
Counter transfers. Counter transfers.
Counter transfers. Yes. Gotcha. Okay, over-involvement, yes. Any more from anybody?
Communication skills. Communication skills.
Yes, the actual skills themselves. Yes, it's interesting, you know, I'm a great believer in the fact that there's a big difference between knowing what to do and being able to do it. A big difference between that and wanting to do it. And also doing it with skill and subtlety. Yes, I imagine that when you're dealing with difficult patients, you need to have a very subtle ability in communication. It's amazing what can suddenly set someone off. We did a little role play in one of our workshops, and I felt sorry for the doctor who decided, who volunteered to be the doctor, because the other doctor who was the patient was quite a difficult person. But this person was difficult because the first thing that the doctor said to him was, "My friend, you are a paranoid schizophrenic." That was the first thing he said to him. It was like an accusation. Immediately came back the reaction, "Doctor, you're wrong." So now the doctor felt threatened and tried to prove from the information he had about the patient that his diagnosis was correct. And the temperature went up, and they were fighting. Eventually, to his great credit, the doctor managed to calm it down and did actually achieve what he needed to, but he made it much more difficult for himself. And I know it was only a role play, but the role play it's something that puts us under pressure. So when we are under pressure, volume of work, problems of our own, job dissatisfaction, all these things in our head, then we are more likely to make those small errors. And just that one thing in the communication area set the communication off on the wrong footing, on the wrong basis. And so it became an aggressive, counter-aggressive kind of discussion, which was not helpful. So when you have this box of tools, why do you think there are so many of them? Well, because they can all be useful. If we only ever use the favorite tool, then that's the only one we'll ever become expert at. I know how to make a pot out of clay. We've all seen people do it, but I can't do it. Well, I could make a very wobbly looking thing. And that when you watch a potter, and yeah, 30 seconds later you can already see the shape, a minute or two later, and there it is. And he made it look easy. That's the thing, he made it look easy. If we can communicate at that level where it's not obvious what we're doing, it just feels right to the patient, to the support group, then we have much more influence, much more control. So it's not enough just to know what the techniques are, but to be able to practice them and go through to that area of almost artistry. Any more? Have we done?
Experience.
Experience, yes, for sure. Yes. Let's see, who's the youngest doctor here? You look pretty young. I don't know whether you're pleased by that or not, but you look pretty young. Yeah, but you don't look so young that I would think you don't know anything. So that would be okay. But imagine my feelings if here I am, an experienced man with adult children, and I have to deal with somebody who looks as if he's young enough to be one of my children. What do you know? So that experience needs to come out as soon as possible. You need to be showing that you do know what you're talking about and that you are competent. And given the nature of the disorders that you deal with, I guess the experience is essential for you to know quickly what diagnosis to make, which route to take. The more often you deal with a patient who is, let's say, non-communicative, then the easier it becomes to handle that particular situation. I can't give you a shortcut to that, but it is a factor. Okay, so I think we may be finished there. Three that are most difficult? What do you think?
Stress.
Stress. So volume of work burnout. Yes?
Dissatisfaction.
And dissatisfaction. And experience. Okay. Right. Those are difficult to deal with, aren't they? For me. Because I can't, well, I suppose I could sit down with you like a psychiatrist and do some therapy with you on your personal motivation. And, in this area, clearly, that just happens over time. Talk to your colleagues. Don't ever feel ashamed to ask your colleagues for advice. But obviously don't overburden them because they're busy as well. But there is no shame in not knowing everything. The greatest stupidity is to stay ignorant and struggle. Then you make mistakes. It's far better to say to a friend, this is a case I have, what do you think? Do be prepared to do that. Okay, look, this business of volume of work and burnout and so on, job dissatisfaction, comes back to time, doesn't it? So you haven't got enough time, too many patients. So what are you going to do about it? Or is it somebody else's problem? It's the hospital's problem. Right. Can we change the number of patients that there are and the number of psychiatrists that there are to deal with them? Not at the moment. It's not within your control, is it? A very wise Christian saint called St. Francis once said, God, give me the strength to change those things that I can change, and the sense to leave those things which can't be changed, and the wisdom to tell the difference. I nearly forgot it halfway through, didn't I? And so, you know, why burn yourself up even more trying to change things which are not going to be changed and which are not within your control? So you might as well change those things which it is possible to do, and that means the things within your own control. Okay, does every patient need the same amount of time?
No.
Not necessarily. Okay, so you have 4 hours and 20 patients. So you allocate, I don't know, 10 minutes for each one. It's a logical thing to do. It's a good starting point, isn't it? Fine. All right, there it is, 10 minutes, 10 minutes, 10 minutes, 10 minutes. It's very easy to get into a kind of mindset which says, I have 10 minutes with this patient. So you give them 10 minutes, whether they need it or not. So which are the patients which don't need as much time? The stable ones. So if I'm a stable patient, I'm compliant, it's going along quite nicely, but obviously I come in because you need to check how things are going. Yes? How much time might you think would be reasonable to give me? Or perhaps a better question is, what do you need to do with me? I'm stable, I'm coming in for a kind of monthly check with you. What do you need to do with me?
Check out whether you complain.
Right. So check out whether I'm compliant. Yes, doctor. Yes, I'm still taking them morning and evening, 20 milligrams. Anything else you need to do with them? Reassurance, yes. And I think reinforcement. Yes. Okay, so you might be saying, and how have you been feeling? How's it been going? Okay, doctor. Yes. All right, are you still feeling afraid to, you know, let's say it's a sociophobe. Are you still afraid to go out and mix with people? Well no, actually, I managed to go to my uncle's birthday party last week. And how was it? Very good. No problems at all. Well done. So there's the reassurance, the reinforcement. Have we done enough? Probably. Probably. So we've kept things on track, we've reinforced and reassured. 5 minutes could be. If we can gain enough 5 minutes, then we run up against the patient who is having a crisis, we have time to deal with them. Have time to deal with them. What worries me is this. It's a time management principle again, that you invest time to save time. Now, if you have a patient who needs a lot of reassurance, who's sliding off of compliance, who's in danger of going into a relapse, but you haven't got the time to deal with them, you do the best you can, you make sure that they know what the drugs are and off they go. What happens? They haven't had what they needed from you, they do have a problem, and they're back again. So in the end, it takes more time. It takes more of your time. It's even more difficult now because from a point where they were needing reassurance, they now almost need re-diagnosis, and the whole thing has come back up. You've gone back to the beginning, effectively. And I think it's fair to say that when you're at that early stage, you spend a lot of time with a patient because that's the only way you can make a diagnosis. So you're putting yourself back almost to that point where it will eat more of your time. Whereas perhaps 10 minutes more with them, 20 minutes, and you might have been able to keep them stable and reassure them enough to continue, or maybe to have time to speak to their family so that the support group really was around them, knowing what they should do to help. There is no magic answer for the time issue and the workload. It's unfair, it shouldn't be that way. Unfortunately, it is that way.
I think one other issue that might have
Yes, thank you.
This shortage of time is to keep the track of those specific patients, phone numbers, and then just keep in contact by phone for like the same day, the evening, next day, something like that. Until you make sure.
Absolutely. Absolutely, yes. It takes far less time to make a phone call from your surgery than it does to actually see someone, doesn't it? But it might save you an awful lot of time and save the patient an awful lot of trauma. Yes? So here are the ones who are my at-risk patients, the ones who are not confident will comply. So a call in a couple of days, how's it going? I'm having side effects, doctor. I did tell you you would have side effects. Do you remember? What are you actually having? And you reassure them and tell them it'll only last a few more days or whatever the truth is. And off they go again. And that might be a good idea. The other thing is that once you've met people, you have a much better idea of those who are difficult. Those who are the ones who are going to need more attention regularly, yes? So why not allow for that when you're scheduling your patient? Of course, if the patients are there and they're kept waiting because you've had to adjust, they will stay, most of them. Perhaps not quite so much in the private sector because they're paying, so they'll be saying, I want to be seen. But very many of them will in fact be quite happy to wait a few more minutes. But if you allow the time that you need for those who are going to be more difficult, then it makes sense to me. I hope it makes sense to you. There is no easy answer to this business at all.
At the end, it is the volume of the work is harder.
Yes, it is. Yes. Unfortunately, that is the nature of what you do. It's a difficult job. So therefore, this worries me. Job dissatisfaction. Why? What's giving you dissatisfaction, doctors?
Stress.
The stress. It's literally the workload and the lack of support. Perhaps not having enough beds and enough funding. Those kind of things. So why? Does this mean that you can't do a proper job? Or not the job you would like to do? Is that the frustration?
I think that the most important part is that you cannot do it properly as you wish the standard, you have. So sometimes you feel obstacles from people or from facilities or
Sure.
that will hinder your
All right. I understand the frustration. I would guarantee that if you went to work in the UK or the US or France or Germany, you would find frustrations in your job as a psychiatrist. There'll be different ones, but they will always be there. So I'm going to ask you as intelligent people to try and put these things into proportion and not to be so hard on yourselves. This is the problem. Given how many people I have to deal with and the facilities I have, the number of beds I have, the funding I have, what is a reasonable performance as a psychiatrist? It's this. You would love to be able to do that. I know. But it's not realistic. So why are you beating yourself up for not doing that? Now you guys know about stress. One of the sources of stress is consistently too high demands being put on you. And therefore, this feeling of inadequacy. So, hey, come on, physician, heal thyself. You don't want to go down that route. You really do not. So, what am I suggesting? That you do a bad job? No, of course I'm not. But don't try and judge yourself on the basis of a job which is impossible for, or a standard which is impossible for you to reach. That just leads to more frustration and a lack of motivation. If I was to talk to my friend here, he's in the business of sales. He will tell you that if a sales target is put way up there and it's clearly impossible to reach, he he will become demotivated and stop trying. If it's put here, it's too easy, he gets bored. If it's a little bit higher than where you are at the moment, it's exciting, it's interesting to try and achieve something that is going forward. So, you know, you must set a level of performance for yourself which is realistic, but it's still something you have to work for. And that is fine. That way you can feel satisfied and motivated. Don't set your targets at an impossibly high level. Demotivation will lead to all of these things, and you're not giving yourself a fair chance to perform well. Sorry, I didn't mean to go into a little lecture to the good doctors, but you know, I see this so often. People who are demotivated about things which they cannot control. So, okay, you have two alternatives. Go someplace else, or learn how to deal with it.
Get the best out of the worst.
Get the best out of the worst, yes, yes. Be kind to yourself. You're clearly doing a fantastic job. Tell yourself that. If nobody else does, don't worry. Tell yourself. Look at the patient's successes you have. Put that into the context of what resources and time you have, and you can see just how well you're doing. Yeah, seriously. It's got to be in that perspective. All right, yes, please.
And frustration tolerance is also a skill. How to tolerate your frustration, the skill which need development.
It is. It is. And how do you cope with it?
Yeah.
How do you cope with it?
I think to put alternative goals, as you say, more realistic goals, and to keep, you usually keep that a side channel for these failures or success or unsuccess. It may happen, and you have to prepare yourself from the start to this.
Okay. Okay. Realism, ladies and gentlemen, please. Yes. You'll never, ever be totally satisfied with what you're doing, even if you get all the facilities. They double the number of beds, they give you more funding, they give you therapists and nurses, and you'll still feel you can do better, because that's your professional attitude. Just don't let it destroy you. Doctor?
I think we have to expect some failures.
Yes.
Okay? And we have to consider that failures may make more progress and more success. This is very important, because sometimes when somebody has some failures, they become more stressed. So we have to consider this and put it in our plan.
Okay, yes, I think that's a very realistic way of looking at it. There will be failures. You know, people, your colleagues in internal medicine, in orthopedics and other things like cardiology, what have you, they have failures. Yeah? What happens to a surgeon who operates on a heart patient and loses them, or somebody in ER? Someone comes in from a road traffic accident and they can't save them. And they have to get to that point where they say, is everybody agreed? Time of death. Yes? You cannot beat yourself up about having done your best. If you didn't do your best, and you look at it and think, I didn't do my best, fine. But there's only one way forward from that. There's a British writer called Oscar Wilde. He was actually from Ireland. And he said, experience is the name we give our mistakes. Yes? So as you can gather, I'm very experienced, because I've made lots of mistakes. The difference is, did you learn from them? So it is an opportunity, as our friend here says. It's an opportunity. So this time I failed. What can I learn about it? It may not help this particular patient, but it may help another patient in the future. So I can build from that. So there is something good that will come out of it, even when it goes a bit wrong. Yes? Make sure you learn from those errors that you do make. Don't beat yourself up, build yourself up. Yes?
If you allow this, there's a difference between job satisfaction and frustration.
Sure.
and job dispatch in general. Because
Sure.
so many things are involved, apart from your own experience or the
Indeed.
crisis.
Indeed. It would be nice if it was simply a matter of we had all the facilities you need and all the backup, and that the rules and regulations of your institution didn't restrict your ability to use your experience and expertise. But unfortunately, it isn't always like that. So I come back to what I said before. There are some things you can change, there are some things you can't change. You have a choice. One of the choices is, do I stay with this institution or do I go to another? If it is so bad, it is making you totally dissatisfied, possibly even giving you stress and disrupting your own stability, let's say, then maybe it is a decision you should make. Otherwise, look at what you can do, where you can work within it, and try and influence it from within. All these things take time. Psychiatry is not highly regarded, I believe, within your medical structures here in the healthcare and in the kingdom. So you are looked on as, you know, less important, perhaps, when the resources are being given out. It takes time. It takes time. We've been through exactly the same process, and it does get better. You need to be as patient as you can with that. Yes, sir.
I believe in one statement which says that think big, start small, and move now. Okay?
Okay.
Because most of the people, they have to rush. They have to reach to a certain point in very short
Yes.
time.
Yes.
So if we think in a very big way, but we have to start in consideration of plan and in consideration of time, and we have to make our plan measurable so that we could evaluate it.
Yes.
So I agree with this statement.
All right. Yes. You know, if you are moving forward and you can see you're moving forward, it is encouraging. Part of the problem is we give ourselves too much to do too soon. It's completely unrealistic, and we don't notice that we have actually made some progress. We are getting better. We're doing a better job. We're influencing the institution. They are giving us more support. Patient results are becoming better. So you need to take encouragement from those things. Yes, it would be great to be there, but look how far you came. Look how far you came. And, you know, where's the next bite-sized chunk that you can take on? You know, somebody said you can eat an elephant, but only a bite at a time. Why anyone would want to eat an elephant, I have no idea. But someone came up with a strange saying. So you must put things into bite sizes which are sensible. That way you can see and feel how well you're doing. Otherwise, the frustration will build up even more. It won't go away if you do that, but at least maybe we can keep it to a sensible proportion. You need it for your own self-respect, your own motivation, your own stability, so that there's something left of you to go home and give to your family when you finish working. Otherwise you will be so exhausted and stressed, there will be nothing left. And then you have your own pressures which come into that. So in a sense you have to be your own psychiatrist here, and certainly your own motivator. If no one else will motivate you, do it for yourself. Find a sensible way, which is the part of the job that you find most satisfying. How well are you doing in that area? Which is the patient whose progress you're most proud of? Focus on it. Yes? Show yourself what you're doing and how good it is. Remember, it's within the context of a restricted environment which isn't necessarily helping you. Take a little break. Yes. Then we'll go into some more things. if you explain to them the circumstances when they should use it, they may sometimes not follow your instructions, but at least they've got some idea what is acceptable as a reason for them to phone you. And so that's another way of doing it, with a structure around it, so that it's not at this time of the night, and it's because this is something that you need me to help you with. The worst thing is that somebody has a relapse because they couldn't get hold of you, and they're already a long way away. So, you know, we have a sociophobe who's 3 hours journey from the hospital. Even coming to the hospital is a major trauma for this person because of the nature of their disorder. So it may well be a useful tool in our communication with them, and it's also a time-saving tool. So we come back to this issue of the time. A phone call will tend to be shorter than a consultation, and so, you know, without having to involve yourself in that, you can actually move the patient forward. It seems to me a very sensible thing to do. Yes, sir.
The structure itself you are working in, for example, your work differs. You are working in private
Okay.
or in a governmental
Fine.
or a strict system which does not allow you to make personal relations with patients. For example, you are expected to write medical reports about patients and medical reports about patients. You are not allowed to make personal relations with patients. So,
Okay. I think in any case, you need a good relationship with your patient, but it should never be personal. That's my feeling. Never personal. There has to be the detachment. You are still the doctor, the psychiatrist, not a personal friend. If you become a personal friend, you're open to manipulation. And you know how what difficulties that can put you in. So that's not a very clever thing to do anyway. It also affects your ability to see objectively what is best for your patient. So that's not a sensible thing to do either. So I agree with you. It should never ever be a personal relationship. It should be a doctor-patient relationship. But that doesn't mean to say it can't be warm, supportive, sincere and caring. All of which it needs to be. But that can be done without being someone's power. Yes, sir.
I have a private clinic and I'm working also in the governmental sector.
Okay.
And I have this problem almost daily.
Right.
When I give to my telephone number to some of my patients, they impede sometimes my work.
Yes.
And it is reflected negatively on the relationship between the patient and myself. Okay? And I think I have just to encourage the patients to call an agency or institute, not person. Because I shouldn't be available all the time. I
No.
shouldn't open my mobile 24 hours.
No.
I could be away far from the country. So I have to teach them how to call for help from an institution or agency. Or even from the community around them.
Fine. Okay. This is part of setting up a treatment plan, really, isn't it? You know, this is what we're going to do, this is what may happen to you, this is how you will feel, this is how long it will take, and this is what you do if you're having difficulties. Yes? Now, we have many resources, so I agree with you, Doctor. Let's not just limit ourselves to, it always has to be me. Yes, if it's a very dependent type of patient who is very fragile, then you may feel that you are the best person to deal with them, but there are other people around you. I think this is a very sensible way of looking at it, that there may be other sources for them to get help, or maybe it's something you can set up within their support group of the family and friends. You know, by educating the family and friends on how to help someone through perhaps a small difficulty that they're having. If it's a major difficulty, clearly they're going to need professional help. That is a different set of circumstances. So the answer, I think, to the gentleman who asked me, and I can't remember who he was now, is that it depends. It depends. It depends on the patient. It certainly depends on how you set it up. If you simply say, "Oh, here, have my number," then if the way you say that So now we're back to communication. It kind of says, hey, anytime you like. You give someone your card and say, have my card, you know, if you ever need anything, just give me a call. Of course, that's what they can do. So I think it's important that you educate them how, when, and which is the kind of hierarchy of their needs. So at this level, support group. At this level, local clinic. At this level, call somebody here at the hospital, in the department. At this level, fine, you need to talk to me. Now that sounds complex, and some people, because you know their particular stage of their illness, may not be able to cope with that, but perhaps the support group can. At least that way, you're giving them every possible support and help, but without it disrupting your work with other patients, or adding to your own personal stress and frustrations because of the fact that you're being run at ridiculous times and it's becoming habitual. And now you're going to have to kind of break the over-close relationship, which in itself may be dangerous for the patient because they may feel some sense of rejection. It's a difficult one, but if you set it up properly, I don't see why it shouldn't be something you can do. You know, sometimes I believe, because we're all patients at some time, maybe not psychiatric ones, but we're all patients. It is very reassuring when the doctor says to you, any problems, give me a call. If you're having trouble with side effects, give me a call. Of course, it usually goes through a reception or something like that, and so they can make it something that they can do at a time which suits them, and perhaps they call you back. But that in itself helps me, as a patient, feel safer. So I'm taking some stomach pills. There may be a side effect. I'm not sure whether it's serious and I should stop taking them. It's nice to know that the doctor is happy to talk to me, rather than I have to make another appointment to go in, and maybe even stop taking the medication because I'm afraid. All of which is helping to move the whole thing along. It's part of that relationship. Yes, sir?
Another factor which is strongly play or give the cultural background.
Right.
It's different. In our culture, especially Saudi culture, our culture, they begin struggling on the personal relationship. In asking a mobile telephone and you say, no, I can't, this will immediately cut the relationship or the relationship. So you need the time just to adjust with him, understanding the background. So I will do you, I have hundreds of patients, so I can't, okay, this is, so you have another way to deal with the patient.
Yes, I think this is fair enough. One of the things that impressed me immediately coming out to the Middle East was how important the relationship is in all aspects of life, in business as well. You know, I will deal with people that I feel I can trust and that I like, rather than the person that I don't feel I can trust and like. And so yes, I think you have to be careful of giving the wrong message. But often, it's not the words you say, you know, I'm busy, you can't call me every time, it's the way you say it. So let's not concentrate on what you can't do with my mobile phone, let's focus on what the patient can do. And so we're back to what the good doctor here said. Yes? I thought he was giving me the text for my next part of the... That's okay, fine. Make it easier for me. Yes, where the heck was I? I have no idea. Yeah, it's the way you say it. So we focus on, fine, you can do this, you can do this, you can do that. Don't bother to say, you can't do this, you can't do that, you can't do that, because now we're cooling that relationship down, and that's not helpful. Which brings me to one of the things on here. Where was it? Oh, in fact, you didn't put it down there. No, you didn't. That surprises me. The business of trust. How important is trust between you and a patient? Crucial? Yes. So, do I trust your experience? Do I trust that you are interested in me? Do I trust that you care about me? Do I trust you not to manipulate me, not to tell all my secrets to my family? Many, many aspects of this will come in. All right, trust then, important. How do we build trust? What can we do to build it?
Being honest.
Being honest, okay? You are, you're psychotic. There's honesty. Sorry, no offense. Yeah. That's being honest, isn't it? Yes, yes. Giving a good service and using your experience well will build trust. I'm being too honest with you, aren't I? There's honesty and there's tact. So honesty, yes. I do not promise you that you will be cured in 3 months, because I know that that's not realistic. In fact, I shouldn't even promise you that you'll be cured in 6 months of your depression, because I don't know. I believe you'll see a significant improvement by then. Okay, that's honest. It's realistic and it's positive. So, okay, honesty, thank you. Yes, sir?
Acceptance
Accept.
and to be non-judgmental.
Non-judgmental. Oh yes, absolutely. You're humans. Are there any types of patients you don't particularly like? Personality disorder. Okay, that I can understand because it is terribly difficult. What about not so much the actual disorder, but the person themselves? Is there any aspects of personality or background that you find less pleasant to deal with?
Over the money. Over the money mission.
So money, those who are
Over
demanding. Ah, yes. I'm sure I'm going to. You don't happen to know a good ENT clinic, do you? Because I'm beginning to think that, seriously, it's all breaking down. I'm getting old. You know, next time you see me, I shall be like this. Over demanding, yes. So, in comes somebody who immediately, or somebody you've met before, you know is over demanding, or starts to behave in that over-demanding way. The support group that comes in and say, take him away, put him in a hospital. You know, he's creating chaos at home and with the neighbours, we're ashamed. And they're very demanding. If you know that's that person, what is going on in your brain? How well can you deal with them? How well can you deal with them?
Setting limits, actually. Setting limits.
Yes.
Especially if they are not like, they are not stable.
Okay, okay. So you can deal with it, but when you see that this is what you have, maybe there's a filter that comes down in your brain. So now you're less accepting, you're less tolerant, you're less patient. Simply because, it's one of those. It could be someone from an ethnic group, because they always give you trouble. It could be someone from, you know, I don't know, it could be old people. You don't like dealing with old people because you're very young, and they always sort of say, you know, can I see a real doctor? That kind of thing. If it puts that kind of filter in your brain, you're not communicating well, and it destroys the trust. So it is important that even if you feel that way, you don't show it. Don't show it. Anything else that can build up or destroy the trust? Yes, sir?
Build up body language.
Body language, yes. And I think particularly when you have non-communicative patients, in certain stages of psychosis, as I understand it, they kind of retreat into themselves. The ability to express themselves is greatly reduced. So therefore the ability to reach them with normal communication is also reduced. It's almost as if they've kind of regressed to a more primitive state. And if we think about that, what was the first language that we had as Homo sapiens? It was non-verbal. And so the non-verbal may become more important. It's certainly very important with all patients. You know, if you talk to our friends, the psychologists, they will say to you, a the first impression of somebody is 10% what they say. It's 90% the way they look and how they behave. That's quite frightening, isn't it? So it is, I'm sending messages to all of you all the time by what I do. And you're sending me messages back. But they're messages which are largely received unconsciously, but nevertheless terribly important. So if our, for instance, yeah, just, thank you so much. Okay, just as an example, I'm in my consulting room. I'm a very important psychiatrist, sorry. Okay, tell me how you've been feeling. Tell me what's been happening to you. And you tell me, and I do this. Yeah? Am I listening? No. Actually, I am. But I don't look as if I'm listening. And that's the problem. And so unconsciously, we may be giving a message which we didn't intend to. We're fiddling with a watch, we're looking at something, we're allowing ourselves to be distracted, all of which says, the doctor is not interested in me. Remember, these people are hypersensitive to these signals, and therefore a very small thing suddenly makes them feel, I can't trust this person. Why should I bother to tell you the secrets of what's bothering me when you don't seem to be interested? So very, very simply, we can encourage that trust through our body language, or we can very, very quickly reduce it or possibly even destroy it just by the behavior, just by the amount of eye contact, the careless gestures, distractive things that we're doing. So easy to do, isn't it? And I know you know this enough, but do you ever get it wrong? Sometimes, because we all do. So, trust built up, trust reduced. I know what you'd like it to be. Here's a kind of summary of some of those points. First of all, remember that the patients are people with feelings. Indeed. Don't criticize, even indirectly. Oh, that's a difficult one. Because if you say to somebody, you're not taking your medication, it's a criticism, but it needs to be said at some point, doesn't it? So how do we handle that kind of thing? Well, maybe we can do it with empathy. Yes. I realize it's difficult to remember when you have other things and you're not feeling very well, however. So maybe we're not criticizing, we're helping. A criticism, whether it's criticism, is in the eye of the person who is hearing it. Don't be tactless. We talked about it. Let's move on. Don't interrupt. Hey, but what do you do when you've got somebody who's over-expressive, over-emotional, and every time they come to see you, they want to tell you the entire history of their illness since 1976. Yes. Oh no, this is 2 hours worth, maybe even 2 weeks. My whole vacation will go. You do have to interrupt them. But if we come back to the one slightly before, don't be tactless, maybe there is the clue to how we should do this. So how would you interrupt somebody who is talking too much or perhaps not focused enough with what they're telling you? Time is of an issue. You need to get on to get to the diagnosis and so on. Have you any ideas how you might do that? Well, there will always be gaps, won't there? You see, what is offensive to people when you interrupt is that it says, don't go that way, go that way. And talking, no, I want you to stop now. So if we instantly push back in a different direction, there's the problem. Distraction could be one way. What we're trying to do is rather come in and go along with what they're saying and then move it on to something else. Come on, you're communication experts. You know how to link and use a question to refocus somebody. It's finding the right moment and the right thing that they say so that you can jump in, and it is an interruption, but it's a helpful interruption. You know, that's an interesting point, Hisham, because now off we go. So it seems to be related to what they want to talk about, but it enables us to interrupt and refocus. Sorry, somebody at the back had a point.
The same point. I agree with you with this point. Shift attitude. Then I can interrupt you.
Absolutely. You know, the human brain loves to hear the words, I agree with you. Or, that's a very good point. Oh, which point? And they pause for a moment while they're thinking about it. There's your opportunity. In we go, and don't go that way, but go kind of over there, and eventually we'll...
Smooth transition.
A smooth transition. A smooth transition. It stops us appearing to interrupt when that's so distracted. Talk to me, computer. Oh yes, there it is. Avoid creating emotional barriers. I think you probably know more than I do about that. Don't be a pessimist. You need people to be as optimistic as you can. It's like a disease almost, pessimism, isn't it? You know, oh, well, it's going to be bad. Yes, it is. The British people do this. They'll sort of say, oh, it's a horrible day today, isn't it? Yeah, I hate it when it rains, you know. And by the time they get to work, they're feeling like doing this to their wrists, and, you know, because everybody has been adding to the pessimism. Eventually, if there's a pessimist in the office, everybody avoids them. Yeah? It's like they have leprosy. Because every time you talk to them, it's, oh, the company's done this, and that photocopy is not working again, and I bet it won't be fixed before the end of the week. And you go, oh, no, I don't want this, please. And so being a pessimist is very unhelpful. It reduces the relationship. Don't show impatience or lose your temper. Ooh. But if the patient is being completely unreasonable, then you may feel like that. Examples of it showing impatience. You know, when you're listening, I've seen one or two of you doing this to me, yes? Here's impatience. Yeah. In other words, shut up, I'm bored. I want to say something. Showing impatience. Yeah, well, look. What we've got to do here is, and you know, the tone of voice is going up. It is an interruption. It says I'm impatient. Use a smooth technique so that you don't have to show that impatience. Don't give false hope, of course. I think that goes without saying, doesn't it? And now we have the ones that build the relationship. These are the ones to concentrate on. Be a good listener. Involved. Active listener, yes. It is something that we've learned from the behavioral psychologists. That be warm, be involved. If you are physically involved in the listening, your listening is more effective, as well as the message it says to somebody. So leaning forward, having the eye contact, making the little noises, more particularly, picking up on things that people say. I was very interested in what you said about that. Maybe we make notes. But you know, there's a difference. I have lots of space here. Yes. Would you feel that I was involved in your case if you were talking and I spent all of my time like this? Sometimes people do it. Yes, it may seem important to you to write everything down, but all the patient sees is the top of your head. They don't know what you're writing down. And if you need to write that much, why not use a tape recorder? Because it seems to be an awful lot. So we need to teach ourselves to use those bullet points, the key things, and remember to look up and still do the encouraging things that say, I am very interested in what you're saying to me. And these little things make a big difference. It's when you're under pressure that you will make those kind of mistakes. So, please, be a good listener. Get people's names right. Another aspect of the Middle East is that people's names mean something. They say where you come from. They say something often about your social status. They certainly relate to your family and your father and so on, and that in itself is therefore a source of pride. It's very important. I mean, my name's important, but I just get the feeling that, you know, getting a name right here is more important, which is obviously another nightmare for me, because sometimes I get the pronunciation wrong. However, this is who I am. I also want to feel that I'm an individual that you remember. So I come in to see you, you haven't checked correctly, you don't actually remember who I am, you don't remember, because you have too many patients. And you've looked down your list and you think I'm Hisham. In fact, I'm Saeed. So you say, come in, Hisham, and immediately the relationship is destroyed. It's as simple as that. What a shame. It's also a great way of interrupting people. You know, if you're walking down the shopping mall here and someone shouts out, Saeed, if that's your name, you'll look round. You can't help it. It's a reflex action. It's programmed into your brain, isn't it? So it's a way of stopping people who are doing this in order to gain an entry to the conversation. So it's a useful thing. Be observant, sensitive and tactful. We talked about it. Give genuine compliments and justified praise. Which are the two most important words in that sentence, ladies and gentlemen? Genuine and justified, yes. If I say, hey, you're doing really well, I could just be trying to sort of say, yeah, okay, pat you on the head. That's a good boy. Well done. It can be seen as patronizing. It may be seen as insincere. So how do we make it genuine and justified? Give a little detail. Ahmed, I think it's really great that you went to your uncle's birthday party. I know it's only just within the family group, but you know, given where you were 2 months ago, this is a major step forward in dealing with your social phobia. This is excellent. Now he feels he deserves it because he can see why. So make sure it is there. But if you can do it, it's encouragement. It's building the relationship. The doctor is interested in my improvement, is encouraging me so we become part of the team. One of the results of that survey that was done, that we talked about earlier briefly, is that consultants said make the patient a team player. You know? It's a joint effort. This is very much part of that. Okay, we have a few more. Be sincere. It really relates to the previous one, doesn't it? Don't make promises you can't keep. Yeah? Don't promise things about how soon they'll feel better. Don't say to them, yes, you can call me at 2:15 when you know you might well be in a consultation and they can't get through to you. Because again, it whittles away. Admit when you are not sure or you don't know. How do you feel about that? You're supposed to be the expert. What about your own credibility? If you say, I don't know how we deal with that. So are we wrong with that one? Does it not apply to you? What do you think?
Yes, the patient respects this. When you tell him, I don't know this, he respects you.
You know, you'll lose more respect by telling them something which is inaccurate or which subsequently is proven to be wrong. But again, it's how you say it which makes the difference.
Yes.
So instead of saying, I don't know, you may say something like, okay, I think what we're moving into here, Saeed, is a specialist area And we have a number of psychiatrists here, a number of doctors would probably say, a number of doctors here. I'd like to talk to one of my colleagues about this because it's an area that he works especially on. Yes, exactly. And so your credibility isn't reduced, in fact it's enhanced because I'm getting special attention. I like that. I've got 2 psychiatrists now. I'm collecting them. Please.
Positive feedback around this personality, because we know commercial feedback. Because in our culture we usually ask about even about commercial product. What's about? So the feedback announcement regarding this one, we give a good feedback. So most of the patient will give a good trust to this. So it depends on what's the feedback.
Yes. All right. Yes, I see the point, and I agree with you there. Okay. Smile and be enthusiastic when appropriate. There's an American philosopher a couple of 100 years ago who said, there's only one thing in the world which is more infectious than enthusiasm, and that's the lack of enthusiasm. Yeah, so if we're a bit of pessimist, oh. But if we can be enthusiastic, enthusiastic is not making promises. It's merely showing belief that this is the right way to go, that you, my patient, can get through this. That's different from making a promise. Yes, absolutely. Think positively. So, okay, that went a little bit wrong. One day I shall go on a presentation skills course and learn how to do it properly. Technology frightens me, it really does. I'm a technophobe. There you are. Perhaps you can give me some help with that before the day is out. When I come in here in the morning, you were here, Doctor, you saw me, I'm sort of panicking a bit about whether it was all going to work again. It worked yesterday, but you know, there are the times when you put it all together and nothing comes out and there's nothing here. So it tends to be a little bit worrying. There we have. But experience will help it. The more times I do it. Okay. Yes, please do.
Usually at the building up the relationship with the patients, usually you have to start by opening and ending. That are very important. How to open the discussion with the patients, how to introduce yourself to the patients so that you could have a best relationship. And how to end. You shouldn't tell the patient that, okay, this is your medication and come after 1 month to see me again. Okay? So opening and ending are very important.
Yes.
As well as the facilitated and obstructed techniques, how we should make the facilitation by saying, very good, you are doing a good job at these things.
Yes. Those little things, those little interjections are tremendously valuable. It's constant reassurance with you, agree with you, support you, help you. Yes, then you have the flow coming. But of course you need to get that flow of data, if you like, from the patient in the first place. And of course they're all very different. Some will like to talk to you and will talk too much. Some will be less expressive and therefore more difficult. So, okay, what do you think then? Here I come, first time you've met me. You know not so much about me, but I've been referred by my own doctor. So you know something about what to expect. I walk into your imposing surgery with a big desk, and you sat behind it, yes, looking very important and a little frightening, because I've never been to see a psychiatrist before. Yeah. How should you greet me? What should you be doing, non-verbally and verbally? What are your feelings? I'll tell you my feelings in a moment. Anyone? How should you do it? Is it not something you've thought about?
I don't feel that you are confident. It seems that you are not you have no confidence.
Oh, so you're looking at me as if I'm doing it? No. I'm just. Yes, sorry. sorry, that's
misunderstanding.
yeah, that's okay. So if you were me, sat here, how are you going to, what's the immediate thing you're going to do? I walk in the door, or you walk in the door, yeah, what do you want to see from me if you're the patient? Let's try it that way. Yes?
I suspect the doctors just when I come in to stand up and shake my hands, okay, and introduce himself. Dr. So-and-so, Markaz consultant psychiatrist. I should give the right position of the job, okay? And I just ask the patient to sit down and to give him an open question.
Okay, okay. Would that be pretty much the way most of you would do it? Yes? All right, fine. So the fact that you stand up is a welcoming gesture. I mean, apart from just being good common courtesy, I think that's important. You have this barrier between you. Yeah? It's perceived as a barrier. What I would like to see you do is come around the other side. So rather than this, that's good, but coming round it to meet the patient is far better. What you're doing is you're showing them the whole of you, therefore they can see the whole of the body language, and you're making an effort, in a sense, to meet them halfway. So that's reassuring, and it is definitely very welcoming. So then we can direct them to their seat. Okay, now what about this configuration here? I know you psychiatrists think that psychologists are all a waste of space. But those of us in the business of training have found that the work of the behavioral psychologist has been very, very useful for us. This is an experiment which was carried out in behavior. A table was placed in a room. There were access points around the room. They were all used equally. Here were chairs round the table. And this one was sat a person. Okay. So, people were sent into the room one at a time, and they were given one of three instructions. The first instruction was, please go into that room and negotiate with the person who is sat at the table. In which seat do you think that most of them sat?
The best seat or the most likely seat?
The most likely seat. This one? Absolutely. Over 97% of people thought that if you were going to negotiate with somebody, you sat opposite them across the table because it was a kind of confrontation. It's a battle of wits. So here we are, the normal setup is you behind your desk. Now do you see why I say please come out from behind your desk? Otherwise it can feel like there is some kind of authority here, some risk of confrontation. Some of the people who went in were asked, it was obviously a third of each, they were told go in there and discuss something with the person who was sat at the table. Where did they sit?
This side.
This side or this side?
This side.
This one. Absolutely. This is discussed in the minds of ordinary people. Yeah, just people like me were told if you were going to discuss something, you know, go in there and sit down. And they naturally gravitated towards this seat. Why? Because it's a kind of easy situation in which to be. It's close enough, but it's not confrontational, so we don't have to have excessive eye contact. We can actually look and have eye contact when it's appropriate and helpful. But we can release the pressure of that eye contact because our body is actually pointing in a different direction. And therefore it's not rude. If I'm sat opposite a good doctor here and I look away, it looks as if I'm not interested. So I may look a little bit shifty, but here I am, he's the doctor, I never met a psychiatrist before, and it's a bit unnerving. And I'm thinking, what's he thinking about me? And so I stare back at him, and it's pressure. It is pressure. If I'm sat that way, I can look away and think, quite a staring pair of eyes, hasn't he? The third group of people who went in were told to go and cooperate with the person. And they sat here. I don't think that's appropriate for what you are doing, but I think you can see that this is terribly important. In the UK, we used to go to our doctor's surgery, the doctor would be there, and the patient would be there. Now, the doctor is there, and the patient is there. Yeah, not even there. So what does the doctor do? The doctor tends to swivel their chair around like that. They still have their computer that they can look at. Yeah? And there's this configuration with virtually no barrier whatsoever. It's amazing how well it works. Patients feel they're welcomed. They feel that the doctor is less authoritarian, more approachable. And so the flow of information is better. Well, the other thing, of course, that they're doing is, I'm very pleased to see from a personal point of view, is that instead of just asking a couple of questions and writing out a prescription, they're actually asking those open questions and how is that affecting you and what else is there? And so the flow of information is helping the doctor make a better diagnosis and helping the patient feel that a better job is being done. So
this has become standard? This has become standard?
Yes, that's become standard. That's become, now I do accept that if you're dealing with psychiatric patients and some of them are the running shoes kind, if you don't know whether you're going to have to take a hasty exit, you may not want them that close. Okay, so maybe you make a different arrangement. It's only a matter of moving a chair. If it's somebody who's psychotic and aggressive, then you may well decide you will put them back there. But be aware of what it does to the communication. It makes it more difficult because the perception is there's a little bit of a contest going on here. Here, it's cooperative, it's open. It seems to be more sincere. Very simple, but very compelling when you think that over 90% of people made those judgments about where they should sit. So their judgment as to what your attitude is where you make them sit. So if you make them sit there, they think you want to be authoritative. If you sit them here, the message you're giving is, come in, talk to me. I'm here to help. We're two human beings. So, let's go back to what our friend the doctor here said. You introduce yourself. I'm Dr. Bobin, blah, blah, blah. Fine. Fine, that's all done. I'm a consultant psychiatrist. How do you feel about saying that? First time you meet somebody. Sorry, doctor. I'm just discussing. One or two people feel it might sound a bit superior.
How I say the message. If I say it in a way that I'm explaining to him my position and my duties.
Right. So you need to have credibility. What worries me a little is that some patients will be in denial. You know, there's nothing wrong with me. I've been told I must go and see this other doctor. You're a psychiatrist? I'm not mad. What do I need to see you for? They never told me I was seeing a psychiatrist. So there could be those difficulties with the word psychiatrist. So maybe simply to say, I'm Dr. blah, 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 blah. I'm a consultant. I'm here to help you. I understand you've been having some difficulties in life recently. Fine, something like that. It says, I'm a consultant. I know what I'm doing. You know, I'm not a beginner. Maybe later on, you know, it becomes obvious and you can more openly say that you are a psychiatrist. But that stigma is attached to anything that suggests madness, mental illness, and psychiatrists are equally attached to that. So it may well just be a dangerous thing to do. I don't know. You must make the decision. I can't make that decision for you. So maybe the seating arrangement, the welcoming, and certainly the introduction of yourself, very important. So, an open question to begin. Fine. Could you give me an example of what you might ask me the first time you see me? A good open question. Let's have a look at how that is.
Usually in our culture, starting by making the word relation to asking the name and the family background and introduce the
Fine.
side of the region, from the south, from the
Excellent.
north.
Excellent. Yes.
Sometimes start with a visit by the player, who's the player that you like, and what's the team you like, and this is a lot of fun.
Fine. Okay, I can see the value of that. We do the same sort of thing, and you have more of the kind of social chat in order to relax them a little. Very sensible. All right. It's also giving you invaluable information already, isn't it? About culture, about attitude, about how expressive they are, how confident they are. So before you go in with, you know, big boots, you've actually got a better idea of what your first question should be when you move into the area of diagnosis. I think that's very sensible. Okay. Be aware, though, that some people, because of their particular personality traits, I'm not talking about disorders now, I'm just talking about the normal personality, will find a very open question difficult to handle. It's too big for them. They need a little guidance. So if you can make it slightly more specific without being closed, then it makes it easier for them. Easy is good at the beginning, because I'm not struggling around thinking, what does the doctor want from me? I'm thinking, I can answer that. Yeah. What happened last week that made you go back to see your doctor? Fine. It's about how you've been feeling, but I could have said, what's been happening to you? Well, all sorts of things. It's too vague. It's too vague. But last week there was an event. It's fresh in my memory. I can have the confidence to give you that information, and so the information starts to flow. You can broaden, you don't have to broaden it or narrow it after that. But just that one thing, don't make it too broad. If it's an expressive person, they'll swamp you with information. If it's a non-expressive person, it will certainly frighten them. So focus it just a little bit. Okay. Yes, please.
Very focused questions presented as a threat to some patients who are mistrust about it.
Okay, how focused do you mean?
Like if you ask what happened last week, what did you do last week? Well, what case happened to you? Nothing happened. I mean, especially we're talking about this paranoid person who traits or mistrust.
Okay, now clearly this is always within the context of what you know about them. So I imagine that they've either been referred to you or you already know them. If you know that's the kind of person they are, then clearly this is one to avoid. So you would perhaps just get talking to them broadly about and how have they been. But if it is a person who is not paranoid, they may well be perfectly willing to talk to you about it because they need to talk to somebody. Maybe the problem is they can't talk to anybody else. Maybe they're slightly ashamed of what's happening to them. They're certainly disturbed by it. They do need a confidant to talk to. So, of course, always within the context of what you know about the condition, which clearly is not my area to comment on. But yes, I totally accept what you're saying there. So now we have them moving along quite nicely. Yes, sir.
One of the most important points here regarding our experience, usually patients coming with one of the family members or the whole family sometimes.
Right.
Okay?
Yes.
Once I tell the patient that you have the right to be seen alone and I have to just make confidentiality issues. Okay? And I ask the family if they could stay outside, and I tell them that if you want me just to see the family member to clarify some issues, and I will keep the secrets that you tell me here.
Yes.
Not to say it to anybody else. Okay? So this is very important. Usually people, they are very apprehensive about these issues.
Mm-hmm. Yeah, well, I can quite understand it, you know. I open up and I tell you something which is perhaps a little embarrassing, possibly even shameful, possibly against my religious beliefs. but I've done it because that's where I am in my life and my condition, and would not be very happy for you to transfer that to a member of my family, would I? So if I think that's there, again, we've been talking about trust. The trust is reduced. But if you make that promise, then you must stick to it. If subsequently you think it's important to release that information to the family, then I think you're probably going to come unstuck in a very big way. Certainly the relationship will go down, so it would have to be a very serious situation for you to go back on that promise, for sure.
Plus, it is, as couples, the relationship is maybe the whole approach you need to make a relationship. Maybe because it is you need the knowledge, the diagnosis, the treatment. The relationship itself is the main item. Maybe different in other specialties, other surgery, pediatric. It depends mainly on other diagnostic tools.
Yes.
But mainly it depends on the relationship to gain all the knowledge from the patient.
Yes.
It's mainly important for us.
Totally, totally. I think all doctors or all physicians could benefit from being better in their communication and relationship building with the patient, particularly if they're going to see them again. It's not like you're going to ER and they patch you up and send you away, but where it's going to be an ongoing relationship, then it facilitates better communication at every stage. But it's not as crucial as it is for you because it's not part of the diagnosis. Or it's not the only part of the diagnosis. So yes, it needs to be there. So now we've got off to a good start. How do you tend to progress from there? You're now actually talking about the disease, and we're looking at some of these difficulties here. Okay. How is culture and religion, things like that, how are those going to affect that discussion? What kind of difficulties specifically now will you get from things like this? Yes, sir.
Because a good understanding of the way how the patient think,
Yes.
even if I don't agree what he say,